The latest guidelines for the management of rheumatoid arthritis, RA, have been updated by both the American College of Rheumatology, ACR, and the European Alliance of Associations for Rheumatology, EULAR. 1. ACR 2024 update focuses on optimizing methotrexate use, suggesting subcutaneous administration if oral methotrexate does not achieve desired outcomes. Emphasizes minimizing glucocorticoid use due to long-term toxicities. Introduces new strategies for adding biologic or targeted synthetic DMARDs when patients do not respond adequately to methotrexate 7 source. 2. EULAR recommendations reaffirm a treat to target approach, aiming for remission or low disease activity as a primary goal. Adjust treatment strategies based on individual patient characteristics, including comorbidities and patient preferences. 8-9 source. For comprehensive details, you can refer to the full guidelines on the official websites of ACR and EULAR. The 2024 ACR guidelines for managing rheumatoid arthritis introduce several important updates. 1. Methotrexate use. Methotrexate remains the first-line therapy. A key update is the recommendation to use subcutaneous methotrexate for patients who do not reach their target with oral methotrexate before switching to another DMARD7 source. 2. Targeted therapy. For patients who have not achieved their target despite maximum methotrexate, the guidelines recommend adding either a biologic DMARD, BDMARD, or a targeted synthetic DMARD, TMARD, over triple therapy, which includes methotrexate, sulfasalazine, and hydroxychloroquine. This represents a shift from the previous guidelines that considered both options equally 7 source. 3. Tapering DMARDs. The 2024 guidelines offer more clarity on tapering DMARDs for patients in remission or with low disease activity. Unlike the 2015 guidelines, which conditionally recommended tapering, the new guidelines favor continuing the current dose over tapering and dose reduction over discontinuation, 7 source. 4. Glucocorticoid use. There is a strong emphasis on minimizing glucocorticoid use whenever possible due to their associated long-term toxicities. The guidelines discourage routine glucocorticoid use, suggesting their use only when necessary, and emphasizing early tapering, 7 source. 5. Special populations. The guidelines include specific recommendations for patients with comorbidities and those in resource-limited settings, adjusting treatment strategies to better address the needs of these populations. These updates underscore a more personalized approach to RA management, focusing on maximizing the efficacy of methotrexate, reducing reliance on glucocorticoids, and adjusting treatment based on patient-specific factors. For full details, the guidelines can be accessed through the ACR's official publications. The EULAR 2023's 2024 guidelines for the management of rheumatoid arthritis, RA, emphasize a personalized, treat-to-target approach with a strong focus on patient outcomes. Some of the main points include: 1. Treat-to-target approach. The primary goal is to achieve remission or at least low disease activity. This goal should be pursued through regular monitoring and adjustments in therapy if targets are not met within 3 to 6 months. Shared decision-making between patients and clinicians is emphasized, ensuring treatment choices align with patient preferences and lifestyle, source 9 source. 2. First-line therapy. Methotrexate remains the preferred first-line treatment. For patients who cannot tolerate it, leflunomide or sulfasalazine may be considered. Combination therapy with conventional synthetic DMARDs is recommended over monotherapy for better outcomes, 9 source. 3. Biologic and targeted synthetic DMARDs. In cases where conventional DMARDs do not achieve sufficient control, biologics, e.g. TNF inhibitors, IL-6 inhibitors, or targeted synthetic DMARDs, e.g. JAK inhibitors, are recommended. The choice of agent depends on factors such as disease severity, comorbidities, and patient preference, 8 source. 4. Glucocorticoid use. Similar to the ACR guidelines, EULAR emphasizes minimizing the use of glucocorticoids. They recommend tapering off glucocorticoids as soon as possible after disease control is achieved due to their long-term side effects, 9 source. 5. Special considerations. The guidelines address the need for tailored treatment strategies in special populations, such as patients with comorbidities or in resource limited settings. For example, lower cost treatment options may be prioritized where biologics are not accessible nine source. These guidelines are based on the latest evidence and aim to balance efficacy with safety, taking into account the diverse needs of RA patients across different healthcare settings. You can find more detailed insights and access the full guidelines on the EULAR website and in publications such as Annals of the Rheumatic Diseases, 8 source. Both the 2024 ACR and 2023-2024 EULAR guidelines for rheumatoid arthritis, RA, emphasize similar goals of achieving remission or low disease activity. However, they differ in their specific treatment recommendations and areas of emphasis. 1. Treatment approach. ACR focuses on a more structured approach with specific recommendations regarding methotrexate, such as switching to subcutaneous methotrexate before adding or switching to other DMARDs. This guideline emphasizes using methotrexate to its fullest extent before moving to more complex treatments, 7 source. EULAR prioritizes a treat-to-target strategy, aiming to achieve remission or low disease activity within 3 to 6 months. EULAR emphasizes shared decision-making, ensuring that treatment choices align with patient preferences and clinical outcomes, source 9 source. 2. Methotrexate and DMARDs. ACR, methotrexate is the first-line treatment, with updated recommendations to maximize its use. This includes recommending subcutaneous methotrexate if oral methotrexate does not achieve treatment goals, 7 source. EULAR. Similar to ACR, EULAR also recommends methotrexate as the first-line option, but encourages combination therapy with other conventional synthetic DMARDs like sulfasalazine or leflunomide to enhance effectiveness, source. 3. Biologics and targeted synthetic DMARDs. ACR. When patients do not achieve their target with methotrexate alone, the guidelines recommend adding biologics or targeted synthetic DMARDs, favoring this over triple therapy. This represents a change from earlier guidelines that had equally recommended both options, 7 source. EULAR. Similarly, biologics or targeted synthetic DMARDs are recommended when conventional DMARDs fail. However, the choice of therapy depends more on patient-specific factors such as comorbidities and preferences, 8 source. 4. Glucocorticoid use. ACR. The 2024 guidelines discourage the routine use of glucocorticoids due to their long-term side effects. The focus is on minimizing their use and tapering them off as quickly as possible. EULAR also emphasizes reducing glucocorticoid use and advocates for their rapid tapering once disease control is achieved. Step 5. Special. CR, the guidelines include recommendations for patients with specific comorbidities and those in resource-limited settings, providing flexibility in treatment strategies based on individual needs, source. EULAR addresses special populations as well, with a stronger focus on cost-effective treatment options, particularly in resource-constrained settings where conventional DMARDs may be prioritized, 9 source. Summary. Both guidelines focus on patient-centered care and optimizing existing treatments like methotrexate, while also emphasizing the importance of minimizing glucocorticoid use. ACR guidelines are more specific about methotrexate, such as switching to subcutaneous administration before introducing new therapies, and recommend biologics over triple therapy, 7 source. EULAR highlights a treat-to-target approach, shared decision-making, and provides detailed strategies for combination therapies and cost-effective treatments, especially for resource-limited environments, 8 source, 9 source. These guidelines reflect the different practices and priorities of the regions they serve, but both offer valuable frameworks for the effective management of RA.